Oral Health Advisory, to the Oral Health Advisory Panel meeting today on March 19th. I'll give some opening slides and I'll turn it over to Ariel since the primary purpose here is to advise her. Um, Purpose of this meeting is for the medical director to consult with oral health experts to inform research and recommendations. HERC decisions are about coverage policy and they affect over 1 million OHP members as well as their families, caregivers, and providers. This is an advisory or consultative body. It's a panel, not a subcommittee. There are no formal recommendations, no votes, no quorums. We do have Dr. Stacy Geisler here as the liaison to the HERC. She is a member. This meeting is not subject to public meeting law, but we do open the meetings and welcome everyone's participation. We structure it more informally than our public meetings. So if you want to speak at any point, raise your hand and Ariel will call on you as she is able. Medical director will decide how and whether to incorporate the perspectives expressed today into recommendations at a future HERC or subcommittee meeting. Meeting logistics, please message Jessica Malmstrom if you have any questions about logistics. If you registered to comment, I don't think we had anybody register today, but like I said, if you want to say something, just go ahead and raise your hand. And Ariel will call on you. The chat is the part of the public record. The meeting is being recorded. Other comments through the chat or question and answer may not be reviewed during the meeting. So the best way to participate is to raise your hand. You have email questions come up that we can't address during the meeting. You can always reach us at herc.info@oha.oregon.
I'm just listening to this.
And oh, that is the end. Those are spare slides. So I will stop sharing screen here and turn it over to Ariel for, if I can figure out how to stop sharing screen, I will stop sharing screen.
And just, Jason, a quick housekeeping thing. Please, as a Zoom etiquette, please stay on mute unless you are talking. Thank you.
Welcome. Thank you all for coming. As Jason said, this is our Oral Health Advisory Panel meeting. And thank you for kind of quick, we don't normally have sort of meetings in this cadence, so thank you for sort of hanging in there while we're doing like almost monthly meetings. And I wanted to just kind of start out. Did anyone have who looked at the highlights from the last meeting have any concerns or have any edits that they want? No, okay. We will kind of take that as
I'm sorry, can you hear me okay?
Yeah.
Yeah. I think two edits that are just relatively minor. By my name it says DMD DDS, kind of implying that I have a dual dental degree, which is kind of cool, but not actual. So if you could just take off the DMD. And
Okay.
then also, I think Heather Simmons' last name was incorrectly spelled. It's SIMMONDS in the
SIMMONDS.
so you have to take off the D. D is not present.
D. Oh, so it's SIMMONS.
Yes, that's what I meant. Correct. Yeah, I
Okay.
don't have it in front of me. I'm just trying to do
No
it from
worries.
memory.
Thank you for
Okay.
telling us that.
Yeah, and then I also had kind of a process question. So it was very helpful to see Jason's slides about kind of the intent of this consultative body. And as I was reviewing, later on in the meeting, we'll talk a little bit about the partial dentures and possible integration of additional types of partial dentures. And one of the comments made there was, OHA followed up saying that this would be a cost neutral benefit. And that statement alone doesn't provide me any assurances from what I know on the ground with operationalizing the benefit and with the management of practices. And so, so I think the question that I have is more of a process structure question. So it seems as though OHA has weighed in. There will be the consultative body that that will likely suggest that's not rooted, that comment is not rooted in fact. How does the medical director then take that and inform HERC
Yeah, so
for
so
implementation?
Herc's job is to recommend on the clinical side. And so if you have advice on the clinical side about the utility of these, that's going to be our job here. Rates are done elsewhere, and the coverage parameters are done elsewhere, as as will become clear in the discussion of various topics, possibly not limited to that, when there may be different opinions and ideas about the business aspect. That's not our task here today. And however, this discussion will inform that task, but we want to keep our focus on the clinical part because we are not actuaries. We are not in charge of Medicaid. We are in a different division than Medicaid, and we talk to our partners there. Dr. Frog, I believe, is going to join us.
He's here.
He's here. Dr. Frog, do you have anything to add to that?
No, actually, Jason, thank you for your comments, and Dr. Chaudhry, thank you for your insights as well. Yes, I agree that this space, as Jason alluded to earlier, is for the medical evidence, review the medical evidence of the treatments. What happens afterwards is, as you know, the steps of looking at this, whether we recommend or not here as an advisory panel, so the medical director can recommend this to Medicaid, and Medicaid will have to look into can we adopt this or not based on finances, others. So there are other steps, but here in this space, as doctors, we're looking into, is this a medically appropriate treatment? And that's all our job here. But from what happens afterwards, I'm happy to talk to you about this, and I believe you're more expert than me about what happens afterwards, based on the history here. So what we need to do is just focus on the task at hand, which is focusing on the medical evidence. And I'm happy to talk to you at any time about what happens afterwards.
Right. So just two more comments then, and then I'll stop talking, I guess, for now. The first one is then, if that's the case, then there should not have been any comment that OHA is stating that this is cost neutral, right? So by OHA presenting that this is cost neutral, that opens the door to then have a financial discussion in a medical based discussion. And then the second piece of this is that while I have the opportunity and the privilege to serve in multiple different meetings, I am finding it challenging where I can advocate for appropriate costing of dental services. And I think that needs to be made more clear in terms of what can be the avenue to present that beyond just talk to your CCOs and they're talking about the rates. I feel like we're missing very vital piece of the service delivery system. And if we can have additional context and a place to provide self-advocacy for the work that's being performed, I think that would be greatly appreciated. Thank you.
So, Manu, I think I have a couple things I can address. I can remove any comments. The comments about cost neutrality came from other parts of the Medicaid program. If members here, if this group thinks that I should remove those, I'm happy to do that when this goes to HERC. And then there are as Jason was saying, this is sort of a dentally medically appropriate, and maybe, even just kind of when you think about like, well, in some situations this is better, in some situations that's better, we need some choices, those types of things, is really what we need to consider. The costs and all the other things that you're bringing up, there are other avenues that I'm sure that you're aware of, or Dr. Frog can hook you into at OHA, that's where sort of those things get hashed out. Stacy, I see your hand up.
Yeah, Manu, thank you for those comments. And it's always helpful for me as a HERC member to hear your concerns. I am the voice for all of you. So, my job as I see it is to bring your concerns to the HERC. And what Jason and Ariel were commenting on is really we're focusing on the science and the evidence and not so much the fiscal implications, but those obviously are very important. And then also, I just want to encourage anyone is welcome. And Jason and Ariel, please correct me if I'm wrong, but all of you are welcome to come and attend to voice your concerns so that other people on the commission can hear what your worries are. Am I
Yeah,
correct in that?
definitely. Yeah. Our next meeting is tomorrow, and we are not going to be discussing this. There's no way I can get that kind of turnaround. But this will be discussed on May 15th, depending on whether if we make any decisions today. At the end of the meeting, I will come up with next steps, and you are very welcome to attend. If you are just interested in the dental, because the HERC and their subcommittees have huge volumes of all sorts of kinds of things, but we can give you kind of a closer time span that you could just pop in. It's a virtually, or if you want to come in person, you can come in to Wilsonville. Any other questions, comments? Okay. The first topic, at our last meeting, you all asked me to look into hydroxyapatite, and hopefully I'm pronouncing that right, medicament. This is a similar a thing that is similar to the actual inorganic portion of human teeth. It's been used in various contexts in dentistry. We currently don't cover it. And I was asked to look at to see if, and that was based on a review in 2023 that didn't find evidence of effectiveness. And this group thought that they were getting provider requests and thought that it would be wise to do an updated evidence review. And just of note, during my evidence review, hydroxyapatite is actually not FDA approved for dental use, but that's okay. We use tons of things off-label. So it was a new CPT code released a couple years ago. When we reviewed it back then, we didn't find a lot of evidence. I did an evidence review, and I wanted to put up front that pretty much all of the evidence out there is for toothpastes and gels and other home products. They're not for professionally applied medicaments. So and many of the studies were done on teeth that were outside of the human body, lab sort. I don't know what you put teeth someplace, and anyway, so not in situ. So I tried to weed out those and just did I tried to look to things that actually had professionally applied medicaments. There was a 2023 systematic review and meta-analysis looking at how this might work on hypersensitivity.
It wouldn't surprise me if that was one of them. And I
Oh,
know
Sarah,
that
could you mute
I
yourself,
think it was
please?
And the vast majority of these were toothpaste or mouthwash, but there were some that were professionally applied in the office. 11 of the 44 studies had an office component, at least, if not totally. They compared it to either no intervention, placebos, or other desensitizing agents. They found that the professionally applied medicaments did have benefit with respect to reducing dentin hypersensitivity. But their meta-analysis had to exclude all the professional applications because of the way that they were doing the statistics. And then there was another review in 2022 looking at 26 studies, about 900 patients, looking at different dentrifices, and they showed the same remineralizing capacity as fluoride dentrifices. Most of these, however, were studying toothpastes again. They did look at some graft materials and use in orthodontics. They concluded that it does have great potential, but further research is needed. The 2018 American Dental Association practice guideline found no evidence supporting the use of hydroxyapatite, either for non-cavitated lesions on coronal or root surfaces. looking at other payer policies, UHC actually has a policy saying they don't cover this. Aetna appears to cover it. It's a little unclear. Delta Dental had a policy that they consider this to be experimental. So in summary, hydroxyapatate's mostly been studied and used as a home product. No studies were found on professional applications for caries prevention. A systematic review did find professional application appears to reduce dentin desensitization. The American Dental Association does not recommend its use in lieu of fluoride-containing products due to lack of evidence. Most private plans don't appear to be covering based on feeling it's experimental. So based on this review, we're recommending continued lack of coverage, which would leave it on for 2025, leave it on line 639, and then for 2027, it would be placed in the not medically necessary file. Questions, concerns, thoughts? I see your hand up, Manu.
Yeah, thank you. So internally within Capital, we also performed a similar analysis and we came up with the same recommendation as well. So while I'm the one who had promoted review of this, I also wanted to share our internal review coincides with what you're supporting here as well. Thank you.
Great. The only thing I wanted maybe some of your input on is I'm recommending that we'll talk about this in more detail, but there's going to be sort of a bifurcation. There's going to be not medically necessary and excluded. Excluded means outside of the benefit package, we don't cover it, even if it's medically or dentally appropriate. Not medically necessary means that it might be covered in some strange exception circumstances. So we could put this excluded, or we could just leave. Oh, I'm sorry, Ahmed, am I saying that incorrectly?
No, please continue. I just wanted to point your attention to the chat. Joanna Wilson was asking us to just speak slower so the transcribe can catch up.
Thank you. Apologies. So as I was saying, my recommendation is not medically necessary, but if anyone wants to propose excluded, that would be an option.
The analysis that my team the Capital team concluded was that that the outcomes of utilizing this is not better than fluoride alone. And so I feel that probably even shifting to the secondary one, which is being excluded, seems kind of more appropriate until more evidence comes out, maybe in the next few years regarding it. But I'll defer to a lot of my other colleagues and subject matter experts like Dr. Allen. Sorry to call you out, Dr. Allen, but or others on the call to weigh in.
Gary?
Well, since my name has been thrown out there, I have mixed feelings on a lot of these. Anything that we can do to encourage minimally invasive techniques for non-cavitated lesions that really have not broken through the enamel, I'm in favor of. But going back to the earlier introductory comments, this is based on evidence, and we're really supposed to be reviewing the evidence, and is it appropriate at this time? I would support not medically necessary, because I do think with a lot of these modalities, as we get more evidence, there may be a time in the future that we might want to approve something like this. And in our practice, our organization, we often do approve things by exception, depending upon the clinical circumstances. So my preference would be to leave it as medically necessary as opposed to excluded. Thank you.
Okay, thank you. Any other comments?
Yeah, I would chime in just for a second. I would definitely agree with Dr. Allen's comment, and I believe it should stay and not medically necessary. Just talking about what happens next for all of you to understand. If we say anything is excluded right now and we submit that request to Medicaid by saying we are excluding these types of services, if we wanted to add it later, we'll have to go through a whole due process with Medicaid or CMS to approve that we add what we excluded into the state plan. And that takes months and months and a lot of preparation. So if something that could be in the soon future, in the short term, medium long term, that we could evidence could change to Dr. Allen's point, then we should keep those on the not medically necessary for ease. Also, another note, my colleagues at the University of Rochester, they have a lot of researchers who are on the National Dental Practice-Based Research Network. And I know this was one of their interests to study in the future, a couple of years. So I believe we might start seeing some new evidence, whether it agrees with the older evidence or contradicts it, but we'll probably be seeing some new evidence over the next couple of years.
Great. And thank you for that clarification, Ahmed, about excluded is a much bigger deal, much higher. We should make it a much higher bar. Or things like implants where we know they're effective, we just can't afford to cover them in our current situation. Any other comments? Otherwise, sounds like you all are in agreement with my recommendations, so I'll move those forward kind of as you saw them. And now we'll go back to sort of the meat of what we've been talking about last meeting, and again, kind of Ahmed and I took all of the discussion from our February meeting and went back over the benefit updates projects. The one document we all discussed, we didn't actually even get to TMJ, and we've kind of updated the recommendations. So I'm going to kind of run through them again and see kind of what you're thinking, and if where we still might need some updates or tweaks, or if everyone's more comfortable with the proposal. So the first one is the benefit update project for just kind of general oral health. And this is looking at a whole series of lines that are currently below the funding line. At our last meeting, if you go in your materials, there's this huge table sort of later in the document. There wasn't any discussion of the ICD-10 codes. And I realize that most dental professionals don't use ICD-10 codes. The minimum for all diagnoses, they have to be allowed what we're calling evaluation of medical management. So if a person comes into you and doesn't quite know what's going on with their tooth and you diagnose them with something that is a diagnosis we don't cover, we still pay for the evaluation and advice, medications possibly if there's something like ibuprofen that's not PA'd. So if anyone has any concerns about any of these, I think at the last meeting, everyone was pretty comfortable with the evaluation of medical management, and that's kind of where I'm leaving them for now. And then going on, there are some CPT codes. These are the medical side codes, and these are probably used more by the oral surgeons in this group rather than dentists. The reconstruction of the mandibular maxilla, there was a note from the last meeting that this can be used for facial fractures. So we're moving it to the facial fracture line. And then the rest of these codes would be not medically necessary, meaning not covered. There was a note about excision of fibrous tuberosities, that this might be indicated in some rare circumstances for denture fitting. And then in that case, it could be approved by exception. Anyone have any concerns about the CPT codes, the medical codes? Stacy, are these all looking reasonable to you? Okay. Picking on Stacy because she's our oral surgeon. And then moving on to the CDT codes, the ones that you all are probably a lot more familiar with. The first couple were for 2D cephalometric imaging. This was moved to the handicapping malocclusion line. It's actually already open from HSD for handicapping malocclusion, but it's not to be billed separately. So that note's in there. And then most of the other, so this is where we get into pretty much everything else is either, except for you'll see there's a couple things that are proposed for some type of coverage. Most of these are going to either be excluded or not medically necessary. And as Ahmed was saying earlier, excluded is kind of a high bar. These are things like the gold foil, where we have a lot of other effective things. We're never going to get to that probable area, so we're just going to exclude it. Versus things like inlays that are metallic or onlays, those are not medically necessary, meaning we could change our mind at some point. So kind of going down through the CDT codes, they're kind of parsed out into those two groups. I guess if any of you have concerns and you want them in a different group, you want something completely never covered, or you could see a possibility that you might make an exception and you would want it, but not medically necessary. Love to hear that input. And then the piece that was a little discussed just a little bit earlier, which is at the bottom of page 10 on the individual document, we start talking about partial dentures. So we currently only cover one type of partial denture on 451. There are a few types there. So the recommendation is to add coverage for metal base and flexible base. I did hear the comment that that you're concerned about, or at least some of you are concerned about the cost neutral, and I can take that comment out. And happy to
Yes.
discuss what you all feel about adding coverage for different types, just the metal and the flexible base partial dentures.
I guess part of Herc's purview is to talk about the least costly alternative. And so, like, we're not going to get into the rates there, but some information about the costs and least costly alternatives and the clinical benefits of one over the other might be helpful to inform that discussion. Like with other medical services, if there are, two alternatives, if one's more expensive, there should be an additional benefit for it. So that kind of input would be helpful and relevant here, but we're not going to be setting rates or payment methodologies.
I see Gary's hand and then Manu.
Yes, thanks. I think this goes back to the previous discussion about, the opportunity to make exceptions, and we have on occasion for flexible based and metal based, if, for example, there's compelling clinical documentation that, for example, an acrylic partial has failed. But I think by adding this as coverage, as opposed to leaving it as not medically necessary and allow us to prove it as an exception, we get into all kinds of complicated discussions if these go to, for example, hearing, trying to argue, well, it's covered and it's recommended by the provider. The least costly alternative argument is oftentimes very difficult with administrative law judges. So having said that, my preference would be to leave those as not medically necessary and still limit it to the acrylic partials. Thank you.
Manu?
I definitely agree with Dr. Allen's comments, and just to kind of promote a certain type of philosophy, right? And so talking through about partial dentures to replace teeth that are missing largely due to disease, like dental disease or tooth decay or gum disease, I think it would behoove us as a community to kind of focus more on the restoration of teeth before they actually become missing. And then trying to then kind of repair a tire after it's been destroyed and has multiple punctures in it. And so, while I understand the intent of this right now is really speaking directly about which partial denture should be a covered benefit, I think when you look at the cost in the of healthcare across the system, it makes more sense to, if we have money to support the benefit, to really focus our energy on full restoration of teeth. Um, After root canals or whatever the case might be, kind of to be more upstream before people actually end up losing teeth and then trying to figure out replacements to that.
Thanks. James?
Aaron, I'm just wondering, I don't have access to scroll through this whole thing. Do we have, is the code for a flipper or interim partial denture, assuming that's separate because that's a separate code?
Do you happen to know the codes off the top of your head?
I don't. I know it's like,
Uh,
I think it's a 51 something or another, but
Yeah, those are covered. It's
they
58,
are.
58. Oh, wait, maybe I'm misunderstanding which one you're asking about. 5820?
Unless it just be like just flipper, if you're only just, replacing one teeth, maybe
D,
just as
Yeah, that's
it's
intimate.
covered.
D5820.
Okay. I just wasn't sure if that was lumped into the whole partial denture mix that was in there. I just want to make sure that that was not omitted. So, okay.
That's actually called out in rules separate. It has different criteria, clinical criteria for when it's
Right.
allowed or covered than the acrylic partial code.
Exactly. Okay. Thank you.
Mhm.
Yeah, it's covered on line 451. Okay. So I internally, OHA dental group, the dental division, and working with us felt that we should be a little bit more agnostic in the type of partial dentures. But I did hear concerns from at least a couple of you that we should continue to not be. Alyssa, did you want to comment?
Yeah, thank you. I do agree that the metal framework partial is in most cases not medically necessary when the acrylic partial is available. I also know we've been having some conversations on the flexible partials and some of those options, and I think part of that conversation should probably also include what's the expected duration that it would last, the inability to add teeth to it, right? So you do narrow the long-term prognosis as well as the future options. Like if the patient loses another tooth, some partials are easier to add other teeth to than others, for example. So as we start thinking about broadening, it actually makes some of the clinical decision making and the longevity come into question. Not with the metal framework. I think that's a no for me for a different reason, but certainly on the flexible partial.
Ahmed?
Yeah, wonderful to hear from the group their insights. It's great to hear those insights. I just will take us back to the first point of our conversation is understanding are those medically appropriate and medically necessary treatment or not? Yeah, that's maybe the first question that we need to answer. Then the second question, as a follow-up on this, are there other cost appropriate alternatives? So I would ask my colleagues here to really just go back again to the first question and give their comments.
Gary?
Yeah, I'll respond to Dr. Frog's question to the group, I guess. But I still do think that by leaving it medically necessary but not covered, and limiting coverage to acrylic partial dentures, that still does give us the flexibility of a plan when it is medically necessary and dentally appropriate to approve those exceptions. And we do that rarely, but we have on limited occasions done that when there's compelling clinical documentation to support an acrylic or a metal base, for example, versus an acrylic, for example, documented allergies or whatever. Those things do occur. They don't occur very often, but I think that we have the flexibility already to make those exceptions based upon medical necessity and dentally appropriate. Thank you.
Thank you, Dr. Allen. And I agree. Maybe I also didn't phrase the question very well because we already established the medical necessity by the missing teeth. So that's maybe the medical necessity start of the point. But the other question is the dentally appropriate. I know we have also some other dentists here from the community who are seeing this and maybe hearing it from their patients, and I would love to hear their insights as well.
Stacy?
So I brought this up last time, and I understand that there's a statute as to how many teeth need to be missing for coverage. So I just want to advocate for this member of the public that the entire HERC heard testimony. And I think sometimes with medical necessity, we focus on dental literature, which is great. But there's also social components to this and self-esteem and psychological aspects that allow people to have confidence when they're interviewing for jobs or trying to make a new start in their life. So I would argue from that perspective that replacement of missing teeth, I would consider to be medically necessary, but also necessary so that they can get going. But I, at the same time, I understand that that's kind of a scary statement because it can be very expensive. But I think all of us were really moved when we heard this person's testimony. So that's just my opinion.
Gary?
Yes, just to comment on that. And, that is something over the years that's been brought up many times as far as I think we could all agree that eligibility for partial dentures is limited to people that are missing 6 posterior teeth or 1 anterior tooth, and so a combination of posterior teeth. That was a decision that was made years ago when we were given a dental budget and we had to size the benefit package to fit the budget. To Dr. Geisler's point and things that have been brought up many times before, there are social as well as functional fit and function needs when you're missing premolars that are in the smile line, that it would be perfectly appropriate to approve a partial denture in those cases, but the rules limit you to the missing of 6 posterior teeth. So, going back and relooking that through the rules process, that's really not in the prioritized list as to making those exceptions. I think we would support that. But also going back to Dr. Chaudhry's comments early on, we oftentimes will expand the benefit package before it's been looked at from an actuarial standpoint. I know that's not our discussion here, but I would just further caution that we do that and look at rates if we're going to be looking to expand the benefit package for those that are from OHA on this call. Thanks.
Yeah, thank you all for this comment, and I'll just I'll take this back to the team for their consideration, and I'll just digress for 1 second here, just to comment on Dr. Allen's last statement about the dental benefit changes. As he alluded to, it's changing back around 2011, 2012, where there were budget constraints and things have change at all, specifically for the complete denture, maybe not as much for the partial denture, except for the number of teeth, but not the frequency of benefit. And understanding again that we are here just looking at the medical evidence. And then once we say this is appropriate or not appropriate from a medical dental standpoint, I know that the HERC team sends this to OHA Medicaid division, and they look at it from fiscal responsibility and see if they can do it or not. That's a different story. But I'm sorry, I'm compelled to say I have read plenty of articles and a lot of evidence in the literature that the cast metal framework is better for longevity, stability, and quality of life. So if anybody has opposition to this evidence, please feel free to propose it. If not, then I still would compel the HERC team to look at the evidence.
James, I saw you sort of looking like you were agreeing with Ahmed. You were sort of nodding. So do you agree that metal is appropriate?
It absolutely, yeah, and the longevity, and I think to Alyssa's point, the ability to add to a partial does increase its longevity. So there's a value add and a cost benefit to that type of prosthesis. So I would concur.
Okay. So it sounds like there may be reasons to cover the metal partial dentures. Does anyone want to argue for it, kind of going along with Ahmed and James? Alyssa, I see your hand up.
I just wanted to clarify that to my point. I was speaking specifically to the request on the flexible, right, where you're at the other end of the spectrum a little bit. I don't disagree at all that you can add teeth to a metal framework, that they're stable. I think that's all true. And I recognize we're having a clinical conversation, not a financial one. I just would request that we have the financial one in conjunction in the appropriate environment, wherever that is the appropriate place for that conversation. But if that is going to be some of the criteria for adding the metal framework, we have to have the same but potentially opposite decision on the flexible side.
So what I'm hearing you say is that folks are agreeing that metal might be dentally appropriate. We should consider adding that to coverage, although you would want a financial analysis. But the flexible base are probably less appropriate and should be not medically necessary to allow for exceptions. Does that
For me,
sort of...
yes, that's where we would consider those on a case by case. If it for some reason is the absolute only option that would work for a patient, we'll make an exception. But as far as like a standard offering and the benefit, you go the opposite direction in the ability to add teeth and some of those other things that help us, some of those other clinical strategies that help us build longevity of the appliance.
I see Manu and James.
Clinically speaking, from my previous clinical practice, the placement and form and function of a metal partial denture is years beyond the ability to encapsulate that with a Valplast or a flexible partial denture base. And so I would view to Dr. Franzen's comments and my personal clinical practice, it would be best to focus on the metal and not promote the Valplast.
James?
Yeah, and I'm not necessarily saying I would promote the flexible or Valplast, but I'll agree with Alyssa's point. There are exceptions where there is such a loss of vertical dimension that the placement of a metal framework partial is just clinically not appropriate and just would never function. So there's a place for flexibles, but those should be taken on a case by case basis.
And I thank you all, and I would concur with you that there is not a strong evidence in the literature yet that the flexible for like the longevity is superior to either resin or metal. Yet there is a strong evidence in the literature for a patient quality of life and patient acceptance. So this is we are talking about the medical evidence, so this is the evidence in the literature. And I would really encourage, and I'm not really trying to be picky here or anything, but I would encourage us to resource back to the evidence in the literature. So I would absolutely agree with all of you that metal by far is the most superior and most reported in the literature to be the best acceptable treatment, longevity-wise and structural-wise. But flexible is not really up in that at that bar yet. It's just there is a lot of evidence on the quality of life and patient acceptance for the flexible over others.
Elena?
Hi. I know most of you. I'm a dentist. I practice at La Clinica down in Medford. And I just to add two pieces of information for accuracy. I know there's been talk that you can't add teeth to flexible base. I agree. They're not the best option. And if you work with the Valplast brand, depending on the lab that you work with, teeth can be added. So just for a full scope of accuracy here, wanted to add that into the conversation. And I agree with keeping them as an option if medically necessary. I've had some patients with allergies to the metal components in either a metal base or the clasps in an acrylic base. And so a flexible base has been the best option for them. So I agree with everything that y'all have said, and I wanted to add those two pieces of my clinical experience.
Great, thanks. So I think we're kind of coming to consensus that to add coverage for metal, make partial the flexible base not medically necessary. That would allow the exceptions for people who have like metal allergies and things like were just mentioned. Does anyone want to argue against that as the recommendation? All righty.
Let me ask a question. Should there be payer criteria to guide that, or should that be up to the dentist to make the best choice for their patient? Like, is there a reason to have HERC criteria to guide which to use, or is it better just to have both covered and be options, assuming the finances are taken care of?
I see Gary.
Yes, thank you. I think anytime we can add either through rules or through HERC guideline notes as to the criteria for when a particular option would be approved over another option. I go back to my earlier statements. We as a plan could say that, for example, an acrylic partial versus a metal partial, if you approve a metal partial as covered, I can guarantee you that in almost all cases, that's going to be what the provider recommends. And because it is the best option, it's not the least affordable option. But when you leave it for the plan, and the plan is always the bad guy in a situation where the insurance company, so to speak, then the burden is on us essentially to show, why are we denying it and only approving the least affordable option. So any additional guidance, if we're going to go this direction, in my opinion, again, I said it previously, we already had the flexibility to approve metal-based and flexible-based. And so adding it to a covered line, I think, is taking us in a direction that is kind of a slippery slope for other procedures as well. Thank you.
So I think Jason's question was, we currently cover the resin base only. Would would a guideline saying when we would cover resin versus metal be appropriate? And if so, do you have any advice for what that should look like? And I see Jane's and Asma.
Osmo was first. Go ahead, Az.
Process question for me. I'm Asma Ahmed. I serve as a dental director for Multnomah. I don't know if I misunderstood. I thought the intent was to add the flexible base as a medically necessary, meaning that we could work with our insurance partners. We could write a case for why we think, as a clinician, this should be covered.
So I think what this group's been proposing is to make it what we call not medically necessary, where it would not automatically be covered. You would have to have a argument.
Yeah. So,
But
go ahead.
But the proposal was to add metal, which would allow the dental provider could recommend either resin or metal without having to kind of justify unless we write a guideline.
Oh, gotcha. Okay. Well, my comment is we've got a really strong working relationship with our Medicaid partner, so I'd be comfortable with something that allows the provider the ability to share, hey, we think that this is necessary for this patient because of this reason, either allergy or, they can't tolerate metal, whatever that may be. I would be comfortable with us having the ability to request it, not necessarily this shall be covered. And Gary,
yeah, I think that's what we're proposing.
Yeah.
Is it wouldn't automatically be covered, but it would be open for an exception, if a provider reached out and said, this is why I need to do this.
Okay, thank you.
James?
Oh, I just want to interject that, there are many patients out there that may need a removable partial denture, but doesn't necessarily mean that they are good candidates for a partial denture. So it's incumbent and best practice for clinicians to ensure that oral hygiene is at a certain level, that patients have the ability to remove it and not remove it just physically. So all of those criteria, I think, are also, I will lean on the clinician and the clinic to ascertain and have those discussions and diagnose prior to moving forward for submitting that this patient needs a removable partial denture, because there are a lot of other factors that do need to be taken account of, because not every patient is a very good candidate for it, even though they may need it. So I just want to interject that.
OHA staff, do we have any rules with the current resin-based partial dentures about any rules that people would have to have a certain amount of hygiene or a certain amount of anything? Currently?
Thank you, Ariel. I was actually going to go to this immediately after this conversation. We currently don't, and that's another thing. For Dr. Allen's comment about coming up with a recommendation to cover resin versus metal, I'm sorry, Dr. Allen, that's really hard to come up with something like this, except if we're really going to point out oral hygiene alone as the only factor. And periodontitis for sure, mobility of teeth, things like that, as the only factors. But if you ask a dentist, would you put amalgam or composite in that filling? That's the dentist's decision to do. And also, if you ask them, as James said, would you use cast or resin? They will evaluate their patient criteria and they will find out. To James' point, do they have mobility of teeth, or actually do they need a lingual plate to stabilize those anterior teeth more, right? So things like that. So they will take all of these into consideration when they're trying to make the decision whether they do resin or metal. And I see that it's overwhelming for you and for the dentist to really advocate for each case if they have to do that. So they'll have to use their clinical judgment, and honestly, we all have license. We are all required to really practice the best evidence dentistry. And if we do bad work, we definitely have the dental boards to get back to. So I just don't want to be the judge of this here. I think if we're really proposing to make something as a rule, I would really recommend looking at when we are giving people immediates versus we are giving people conventional dentures. This may be a rule that maybe we need to look at, because I've started seeing it, well, we don't have anything there. I'm reviewing all our coverage criteria right now, so there's a lot there that needs to be reviewed. But just thinking about, I've seen patients who got the immediate and then like 6 months later are getting the conventional because the immediate didn't work. So I think there is an opportunity for us to look at rules, but maybe not exactly in would we use a resin versus cast, except for the period conditions. And to just make and I believe our dental plan clinicians who are here are very, very aware, as James mentioned, not every patient will be eligible for a metal partial from a clinical standpoint. And specifically that our patients are usually in the moderate to high risk and usually have moderate to severe periodontitis in some of their teeth. So at times, you're most likely not going to get there. So there will be like your smaller subset of patients who are eligible for partials and have wonderful oral hygiene, no teeth mobility, get the care of it. And those will be the people who, as a dentist, if I'm treating that patient, I'm 100% choosing the cast metal for them. No question. So I think this is my 2 cents here. I think we definitely need to look into rules, but might not be necessarily in resin versus metal in this area. It might be a different idea.
I see Stacy and Jonathan.
Yeah, I think that's a great idea to look at the rules, and I just would advocate that we look at the number of teeth that are being included, just again, based on this testimony that I heard. So that would be my request, is to look at all of it. Materials, indications, hygiene, as well as number of missing teeth.
Okay. Jonathan?
Yeah, I definitely agree with Dr. Geisler there in terms of, I think there does need to be a possible revision or a review of the criteria. I don't know if this is the right forum. I think we're kind of discussing a different section, so I would love to be included in that conversation if it does come around. Regarding kind of the discussion around acrylic base versus metal base, I'm wondering if there is a strong opposition in this group to keep the metal base as not medically necessary, because I think at least what I've seen is the majority of these patients that are getting partial dentures, they are moderate high risk caries. They might have periodontal disease. And so if there are those kind of shining star patients that would really benefit from a metal base partial denture, would that be a better steward kind of our responsibility to, the taxpayer money? I know we're not kind of the actuaries, we're not the financial kind of responsibility people, but would that be a better way to kind of control or kind of guide the use of our benefits that we're allowing to kind of default to the acrylic base, but give providers an option to either advocate for their flexible base, if there is, loss of vertical dimension, or a metal base, if, this is a really long-term solution for that patient that would really benefit them the most, instead of giving them that default of you can choose metal or acrylic, because I think a lot of the dentists on this call would agree, like we would most likely pick metal base.
Anyone else want to? I had kind of heard sort of a general agreement that we should add metal. Does anyone want to kind of respond to that? The other thing, as Stacy pointed out, is we can look at the rules. HERT could actually look at a guideline. There's ways that we can we can try to be a little bit more detailed rather than just sort of open. And whether that's a guideline or a rule, or actually sometimes both, we write a guideline and then there's a rule that might even go into more detail. Gary?
No, I would just endorse Dr. Geisler and Dr. Kim that, if we're really looking at expanding the benefit package with reduced rates, which is really the environment we're in, I would go on record as preferring looking at the years for replacement because 10 years is too long, and also the number of teeth that have to be missing as opposed to expanding to for example, a cast metal or a flexible base partial. I think that we would really be providing a better service in that regard, unless we're going to have some miraculous increase in rates. Thanks.
Okay, so definitely a desire to look at, I have materials, indications, hygiene, number of missing teeth, time between replacement, that all is issues. I guess either Ahmed or I think Jessica Dusek has joined. Thoughts on your end about whether that should be a rule or whether that's something that should go in as a guideline? Or anyone else who's here that is involved with the rulemaking for the dental groups at OHA?
Yeah, thank you, Ariel. I think one of the criteria, and I did join late, so I don't know if I missed it, was not only the number of teeth, but which teeth, because I know there's some rule about it being anterior, and then there's been discussion about the need for partial dentures for just molars, really, for chewing, even if it isn't for the anteriors. So I know that was another discussion item that's been up.
Okay, I added that to the list. Okay, so these changes that we're proposing won't take effect until 2027. So we have time to do the rulemaking process. And it sounds like there is an interest and possibly a need to look at partial denture rules. So I think what I'm kind of leaning toward doing at this point is proposing coverage for metal, but not flexible base, but leaving flexible base not medically necessary, so you could use an exception. And then letting Jessica and Ahmed and the other folks over in the dental division over the next year and a half look at the rule and update that. And there's lots of public input in that whole rulemaking process. So obviously you are all welcome, invited, encouraged to participate in that process. All right, is that where we need to, does that feel like a reasonable sort of wrap up for the partial denture discussion? Okay. Going back to our general oral health, there's most of the other things here, kind of going back to our not medically necessary excluded. We are moving a couple of codes for malpositioned teeth to the handicapping malocclusion line. That's D, yeah, right, and you can see it right there. Otherwise, everything is not medically necessary or excluded. Anyone want to pull out a particular code or a group of codes or anything for further discussion? If not, I'd like you to go back up in this document, way back to it'd be your page, it's page 2 in the general document where we start looking at guidelines. We do have some general dental guidelines, and the recommendations are really pretty straightforward. So we're no longer going to have included on lines. It will be medically necessary or not medically necessary. So that's where, and instead of having a line 341, it'll be code group 341. And then we're putting in a date of last review. This has been asked of us by various stakeholders. It's helpful for them to know when this has been last looked at. So there's the dental implant removal. For the handicapping malocclusion, we're putting in some wording about cone beam CT, and also that orthodontic and cone beam CT are included only for children under 21, as well as the young adults eligible for the young adults with special healthcare needs. And then any other orthodontic services are not part of the Oregon Health Plan benefit package. And then kind of going back to the changing kind of wording to make things medically necessary, not medically necessary. And then the decoronation of an erupted tooth is just some straightforward changes. Anyone have, oh, Dana, I see your hand up.
Hi, thanks. Yeah, I think just scrolling back up to page 2. Yeah, right there. The former letter D, treatment is only medically necessary when the patient's free and clear of active decay. To me,
that should be D. I don't know why D got crossed out. Maybe because the and before it.
Yeah, and I guess to me, and I'm not clinical, but when I read that, the free and clear of active decay to me is more of a dental appropriateness versus a medically necessary. It's not because they have the decay that's treatment is available. It's that the treatment is only available if a certain condition exists. So I just raised that question, and if any of the clinicians have thoughts on that. But I guess, and I don't know how. I know the term medically necessary is controversial and doesn't necessarily mean medically necessary in all cases. And so, but when I read that, to me, that just grammatically doesn't quite sound right. And so I'm just curious if that's something that we would change in a guideline note, or if that's something that usually shows up in a rule. And I'm still unsure about whether there are any guidance about when to put something in a guideline note versus when to put something in a rule. So
good question. So medically necessary is out of our hands. That's like a general national term, and the medical folks have also been bringing that up. Like, this is a weird term, but we're stuck with it. What do folks feel about part D there? D's not meant to be crossed out. Or maybe we meant it to just be its own clause because it looks like it got separated.
So if I may, so just be a little more precise here. Medically necessary is a national term. It is a term of law at the federal level. However, it is defined by the state. And when HRC makes a policy, that defines what medically necessary is for the state of Oregon for OHP under this benefit update project. If HRC remains silent and just says the service is covered, then you go to the general definition. And so the HRC decision needs to be consistent. So if treatment A is clinically better than treatment B, we really can't say that treatment A is not medically necessary. We would have to, there would have to be a rule saying that was out of the benefit package if it's not covered. So it is a term, our HRC decisions need to be consistent with the definition based on clinical factors. There are limits to the benefit package, as we've been discussing. So for number D there, if it isn't, if it isn't clinically wise to treat a patient unless they are free and clear of active decay and periodontal disease, then it's perfectly, HRC could put that criteria in, and that would make sense. If that clause, the reason that clause is there is to control costs, and it's not what's best for the patient, then we should remove that. And if that needs to be put in there, it should be in rule or somewhere else. I
thought we put that in there previously because of it's
clinical reasons.
Harmful to put braces and things on people who have active decay.
Right. So
I'm not arguing that shouldn't be covered. I'm just saying the way it's worded is confusing to me, and I just was looking for some clarification about whether using something like dentally appropriate is more appropriate versus medically
I see,
necessary.
I see. Dentally appropriate versus medically necessary. Yeah, we
Yeah.
can, Ahmed, let's take that offline and come to a conclusion about how we do that.
And I apologize. This is Liz, to interrupt. It looks like because Ariel, you struck and that you did mean to strike D and have this be its
I
own
think,
standalone.
yeah,
So
I think
I,
it is supposed to be its own
I reversed
standalone.
that. Okay, thank you.
Stacy?
Yeah, I just want to, it sounds like this has been addressed, but it's not the standard of care to apply orthodontic devices in anyone that has active caries or periodontal disease. And in this whole context, it's for orthodontics, cone beam, for craniofacial anomalies and handicapping malocclusion. And some of these would be surgical candidates. And we just don't do this kind of treatment in a patient that has active dental decay and periodontal disease because there's more harm that's created. So I don't know if that's helpful, and maybe everyone knows that, but
Yeah, so I think that whether we use dentally appropriate or medically necessary, there's a good clinical rationale for that, is what you're saying. I think
Yeah.
it sounds like that's non-controversial. It makes sense to this non-dentist. So whatever that's worth.
Okay, great. Okay, great. So I made some notes. We'll do some offline discussion about what used to be Clause D, kind of internally, and see if there's any need to change that wording. But it does sound like there's definite input that you all have that we should keep that in some form. Okay, great. Any other comments about anything in this general oral health before we move on to TMJ? Okay. So the last thing on our agenda is the relatively straightforward, I know this is pretty controversial, topic of a TMJ. So you all know the TMJ, the jaw joint, can develop arthritis or other problems. There's lots of treatments that have been proposed. Some of them are just advice like eating soft foods, don't chew gum, etc. There are medications that have been tried, PT, oral appliances, surgery, injections into the joint, etc. We currently don't cover anything for TMJ, which is, I should say, we cover somebody to come in who has perhaps jaw pain and be diagnosed with TMJ and to receive education on, self-care that they can do at home, things to avoid, all of that's covered. If there are medications like ibuprofen that might be helpful that are not PA'd, that is being covered. So um, there is a small amount of treatment covered for TMJ, but it would basically just be what the advice you could give in the office as well as medications that are not being PA'd or controlled in any way. But surgeries, splints, etc., are currently not covered. They're on the two uncovered lines. Just as a note, there are two CPT codes, which are the medical codes for injection and aspiration and/or injection into the joint that includes the TMJ that are on a covered line for arthritis. But that code is a very generic code and includes lots of other joints. So it's unclear if the intent is that HERC actually wants this covered for TMJ. I'm assuming that they put those codes there for coverage of the other joints and assume that TMJ will be on the lower lines, but I might be assuming a little bit too much for that. Looking into other payer policies, private insurance tends to treat TMJ as an optional service. So if your specific plan has a TMJ benefit, then they have coverage criteria. But many of the specific plans within their umbrella do not have TMJ benefits, so someone would not have any coverage. the staff recommendation is to put all of the CDT and CPT codes in the not medically necessary group, which would allow some exceptions. And then the diagnosis codes would be the evaluation of medical management, which is what would kind of continue the current coverage of you can come in, you can get advice, you can get non, medications that are not being controlled. Any concerns, questions? Anyone want to jump in? Except for there was one that was a diagnostic arthroscopy of the TMJ with synovial biopsy. I was proposing that as diagnostic, whether or not you all feel that that should be. Stacy.
And forgive me if you've covered this. My practice, Ariel, I do see patients that present with TMJ pain and they actually have rheumatoid arthritis or psoriatic arthritis that's affecting their TMJ. So for those patients, there would be coverage. I know it's rare, but it does happen that they have autoimmune disorders affecting their jaw.
So according to the current code placements, there's injections, but not surgeries. However, if somebody does have like a rheumatoid or an autoimmune arthritis, you would have to go through the exceptions process and say this person needs this procedure because of whatever reason.
Yeah, it's interesting because we get referrals from rheumatologists, that are asking for help in managing these patients. So it's rare, but it's just something I think you'd want to consider. So
yeah. Ahmed?
Thank you, Dr. Geisler. I was going to double that, like second the idea of there are, as Ariel, we had that discussion prior, there are some medical cases that require some small intervention from a dental standpoint, whether it's injection, arthrocentesis, or like something like that. I don't, as Dr. Geisler just mentioned, it's not on every case, and it's definitely selective. And just so our colleagues all are sure aware, most of the people who get TMD, it's kind of non-resolving. So once they have it, they hardly resolve at all. But it just really, I don't wish for my worst enemy to have a TMD pain because it's not something that anybody wants to live with. So understanding keeping some options for flexibility of approval by exception is very, very important in these cases.
Okay. And that's what we would do with the not medically necessary. There would be allow approval by exception.
And if they are covered under medical,
I think that the difficulty here is that, if we're saying it's not medically necessary and there's a patient, like our policy would need to support that the treatment is not beneficial. And what I'm hearing is exactly the opposite. So we're going to have to think a little bit more how to thread that needle.
Jason, thank you for mentioning this. Absolutely, you're right. There are some cases that you can't argue that, and you will lose miserably if you go in front of a judge with being medically necessary or not on some serious cases. But the majority of cases will not be that serious. And if we're talking about the dental piece, if we really go back to things like splints and so on, and I think you can see my comments there, but like definitely the literature so far doesn't have like a strong evidence towards like splints yet. It is the common practice in all the specialty. This is right now called orofacial pain. It used to be TMJ specialty before. Now it's a recognized specialty in dental called orofacial pain specialty. And this is the first line of treatment. Is given like a guard or a splint. Try to maybe either rule out it's a dental cause or it's actually a joint problem. So that's one of the things. But the injections, the arthrocentesis, and as you remember, those codes actually are inclusive of other joints as well. So really any medical professional could use them in any joint.
Stacy?
Yeah, I just would say what's interesting or challenging for us is that the patients often will present with joint pain. They'll be referred into a dental setting, but then what comes up over the course of the workup is they actually have autoimmune disease, and that is actually medically managed. So we'd want to have a pathway that people could have an assessment or evaluation. That would be really important. You can imagine how frustrating it would be. You have rheumatoid arthritis, it's affecting your jaw, and you can't get in. That's just not a good thing. But as Ahmed was saying, the bulk of the patients that are presenting with facial pain, TMJ, TMD, it's bruxism, airway issues, and they don't necessarily respond well to surgical management.
Okay, so I'm not hearing a lot of argument that these should be covered. As I mentioned, we do cover the CPT codes for injections on the rheumatoid arthritis, which includes a whole long laundry list of medical reasons for arthritis on that line. Any other comments or anyone have any concerns? Gary?
I guess just for clarification in my own mind, I think these are all very relevant points that, you do get patients, and oftentimes, from a medical standpoint, if they're complaining about a TMD problem, it's referred back to the dental provider by, a lot of times they'll show up in medical and medical refer back to dental. And what we're saying is the evaluation appointment would be covered. And that's fine. In the workup, number one, it's difficult to find anyone that will accept TMD referral in our experience, even for evaluation. But once a underlying medical condition is determined, as pointed out by Dr. Frog and Dr. Geisler, that they have an underlying autoimmune disorder, for example, that at that point it reverts to CPT codes and is billed to medical. Is that what I'm understanding?
So the evaluation would I'm hesitating a little bit because I know most dentists don't use ICD-10 codes. If you use the ICD-10 code in an office visit general code, that would be paid and covered. If you wanted to have somebody who's like a oral surgeon look at somebody who does use ICD-10 codes, the evaluation, if they coded TMJ, would be paid for. But the treatments, other than like I had mentioned, sort of just advice and low-cost meds, would not be covered. Does that answer your question? But except for those two codes that we currently have that are medical injection codes, which an oral surgeon could use as well, and a dentist is free to use them as well. Stacy?
Yeah, Ariel, my experience with this has been that usually they go back and they're managed with biologics.
Yeah. I mean, they're doing amazing things now with autoimmune.
Yeah, it's incredible. I guess the important, from my perspective, this is just what I've seen in my practice, is we just want to make sure we capture these people so we get an accurate diagnosis and we can support the rheumatologists. And so that's.
Okay. So I think the proposal kind of addresses that. It would allow you to do an evaluation, and then you could come up with a exceptions argument for very specific cases And obviously if somebody's got like facial trauma that affects their TMJ, I mean, there's lots of cases of it where I could see an exception being something that would be very appropriate. Great. All right. Well, um, that was our third item on the agenda, and I think we've got at least I feel like I'm pretty comfortable with where all you are going with that. So next steps. First of all, is there any other? Oh, Gary, I see your hand up.
Yes, I do have some other items I want to put on the radar.
Yeah.
They really were not agenda items, but I think
Sure.
it's something that needs to be looked at, particularly from the standpoint of the guideline notes. And in fact, these are all related to guideline notes. But for guideline note 53, which is basic perio, and this covers gingivectomies and provide guidance for when gingivectomy would be covered. The code 4212 included in that on that guideline note is actually a different procedure altogether. It's just removing the gingiva so you can get access to the tooth to do a restoration. And that's actually identified by rule as not a separately reimbursed procedure. So my point is, I don't think it's appropriate for this guideline note. And I'm
Okay.
happy to listen to any dissenting opinions.
Let me see if I can pull up guideline note 53. That wasn't one that was in any of the materials, I don't think.
No, it was not. So
Okay, yeah, that's no problems. If we have an incorrect code, that is definitely something that we want to change. Let me, come on, open up. Sorry, computer gremlins today. What? You just closed my entire document? Okay. So I'm actually going to it's a very short guideline, so I'll drop the entire thing in the chat. So that's D 42, 10, 11, and 12. Are you saying that we should just strike D 42, 12?
correct. That would be my recommendation.
Okay. And I can take this offline with our dental folks and just double check with them. But yeah, thank you for pointing that out. I'm happy to make any change.
And the other thing that I hesitate to bring up, because I know we've beat the frenectomy guideline to death already.
No, not the frenectomy guideline.
But actually, this was I missed this, and this was brought to my attention by Dr. Chaudhry, so he might want to chime in. But we discuss the buccal labial frenectomy. Speaking to the dental side of this guideline note, and we discussed the lingual frenectomy, but we did not discuss in this guideline note D 7963, which is frenuloplasty. And although that's really kind of been a very rare procedure in our experience, as far as managing the benefit package, I'm just raising the question, should it be included also as part of this guideline note from the dental perspective? And I'll defer to Dr. Chaudhry since he brought it to my attention first. If he's already resolved this in his own mind, maybe I'm just complicating things.
So that's the guideline note 48, frenulectomy, frenotomy.
Yes.
Okay. I can look at that, and we again, look at kind of put our heads together as staff and see if that needs to get added. And if we do add it, do you have a sense of where it should be added? we have D7961 as being basically, so we have D7961 and D7962 are only covered for children over age 12 and under age 21 when they cause gingival recession or movement of the gingival margin. So would you include D7963 and any relevant CPT codes in that same section?
These are, actually what I'm going to do is pose this question to Dr. Frog and Dr. Geisler as surgeons as far as utilization of this code beyond the guideline note. I don't feel like I'm in a position that I could recommend one way or the other. I'm raising the question is, where does this guideline note most appropriately, or this procedure code most appropriately fall? If we're going to, allow coverage for it, what are the guidelines that would apply in this case? And again, I apologize for bringing up an old agenda item that we thought we'd put to bed. Thank you.
Okay.
I seem to recall that this D7963 is beyond the scope of that current guideline. It's kind of a separate issue, but let's see what Dr. Frog.
I will look into it. Yeah, Ahmed, do you have something to say?
Yeah, I would just say thank you, Dr. Allen. And definitely very, very rarely that surgeons are really spending all the time to really detach the muscles and do the Z-flap for the frenuloplasties. As like secondary intention healing is perfect. So that's why people really hardly use the frenuloplasty. They'll just frenectomy, like really, they hack it out and that's it. And some of them, like many people right now have like their lasers also, like whether it's CO2 or the OPAD, they do it with lasers. So hardly anybody really uses that, like the Z-tub flap and the attached muscles. But I have to say, yes, there might be some cases that really need it because you're worried of that it comes back and reattach. But those are really rare. And I'll defer to Dr. Geisler.
Dr. Frog, surgeons don't hack. We might struggle, but
that's a term we use in New York, so I'm sorry about that. We always go to hack it out.
I don't know what everyone's opinion is, but we try to avoid that word hack. But Ariel, I think I was helping you with this initially way back, and I think the heart behind this was try to simplify the terminology to make it standardized and consistent. Do you remember all the discussions? Because there's like 15 different terms and it can be very, very confusing. And we want to make it easy for everyone, all of you, that when you're coding and to provide some standardization. So my opinion is that the plasty is a very rare situation. And I agree with Dr. Farag that this isn't something that I've ever coded in my time as a OMS, but I don't know if Dr. Chandri's still on the call, but I don't know if you're seeing this with your providers, perhaps it should be revisited. I hate to say that, but my opinion or my experience is just this is a code that we're not really using very frequently.
Thank you for the opportunity to weigh in, and Dr. Allen, thank you for promoting. I had actually forgotten about this, this concern of mine that I had raised to you separately. And so, just to provide additional context across the entire all the stakeholders that we have here, is that a lot of the the providers that were previously using 7961 and 7962 have turned their attention to, realizing that they don't have an avenue of achieving reimbursement through 7961 or 7962 because of the rules that have been placed, have turned into 7963 and are actually promoting medical necessity through 7963. And so and then also in line with EPSDT as well. And so any type of support that HERT can provide around, when is it appropriate and when is it not appropriate, I think will help the administration of appropriate care.
Okay.
Dr. Chaudhary, thank you so much for mentioning this, and I really appreciate you bringing this up because this is a great conversation to the point of, well, if they are resourcing to this, are they really documenting in their notes that they are really having primary closures and Z-flap to release the muscle? And if they don't, then they are not using the code appropriately. Then they are either upcoding, downcoding, or just like, I don't know, whatever that term will be, but they are absolutely not using the code as it intended. They are just having like a workaround. And I don't believe that any dentist wants to do that.
Okay. How about I take that offline with Ahmed and our other dental folks, and we'll look at D7963 and maybe either follow up with you all via email or at our next meeting. If I could quickly go back to the D4212, that is gingivectomy to access for restorative procedure. So I just wanted to clarify, Gary, did you want that widely covered? Like that should be covered without a guideline, or because currently it would be really limited in the guideline.
Yeah, and that's I think part of the point. It is pretty widely used
Okay.
because you need to get access to restore a tooth. It's just not a procedure that is identified as separately reimbursable. In other words,
Okay.
it's included as part of the restorative procedure. So I think it's addressed by rule, and I think it complicates things when it's here in the guideline note.
Okay. Thanks. Thanks for the clarification. Okay. Perfect. Okay, so I think that answers my question about guideline note 53. I'll probably put that on like a consent agenda going forward for like May, and then we'll look more into the D7963 and maybe get back to you all if we have more questions on that one. So thanks for bringing up those as possible issues. And sorry, I didn't have when things are brought up on the fly like that, thanks for putting up with us trying to kind of scramble a little bit to figure it out. But we will look into that. Any other business? Okay. So I just wanted to go through next steps. That one guideline, I think D4212 should be on the, what is the NTTBS list, Alyssa?
Not to be billed separately.
Oh, okay.
Oh, sorry, my letters are off one.
No worries. I will check with our rules folks and make sure. I'll just make a
Yeah,
note
just
to myself.
to point that out, like I think it specifically should be in the not to be billed separately. Because it is in rule, but most of the codes that are in that rule are on a not to be billed separately designation.
Okay. I just made a note to double check on that.
Awesome, thank you.
Okay, so sort of unfinished business from this, I will look into that D4212 as well as the frenuloplasty, and if it's just going to be if D4212 just needs to go on the not to be billed separately list, and we can do that just with administrative change, I'll bring just a consent rule to probably the May meeting. If there's other things that need to be done, I'll get back to you all. So what's going to happen now? The revised general oral health as well as the TMJ that proposal, actually just as you saw it, and the hydroxyapatite, however you say that, proposal as you saw, those will come to the May HERC meeting. That is, our meeting is May 15th. It's in Wilsonville, and it's also online, virtual. So you are all welcome. Keep an eye out if you're not already signed up for our listserv. Keep an eye out for like an agenda, or you can send something to herc.info if you just are having trouble finding anything about the meeting. You are all welcome to attend. There will also be a public, we release everything a week before the meeting. So if you had some last minute comments that you or someone that you, a colleague, want to put in, you're welcome to do that. We have been putting out our meeting materials 6 weeks ahead of time, but because this material's already been out in public because of this meeting, it won't be out in our early packet. But again, if you're walking your dog tonight or in the shower or whatever, and you have a sudden thought that you want us to consider, HERC.info is a great place to send that to. Otherwise, expect that this will be discussed further at our May meeting. And Stacy Geisler is your liaison, so she will be your voice at the Value-Based Benefits Subcommittee and the HERC meeting. But again, you're all welcome, even if you just want to attend, just to listen in and see what will happen. If you wanted to give formal testimony, we ask that you sign up. You're welcome to give just general testimony at some point as well, although we still encourage you to sign up. Any other steps here, Jason? And the benefit updates things that we were talking about, just to reiterate what I said, all of that doesn't change until 2027. It's part of a whole larger restructuring and process.
No, just thanking everybody for bearing with us about the distinctions with medical necessity and the benefit package. That's part of what we're trying to untangle here. So appreciate all the good information.
Yes, and as always, I just want to express my appreciation for all of my dental colleagues who are willing to share your time and expertise with somebody who has very, very, very little dental training. I really appreciate you all. Stacy?
We appreciate you, Ariel, and how hard you're working on our behalf. So thank you for that. And can you walk us through the proposed rule changes for partial dentures? The discussion, we had a great discussion today. I know Dr. Kim is interested in being a part of that. Just for the whole group, could you just walk us through how that process is going to occur, just very briefly, and how people could participate if they wanted to be a part of those discussions?
So what the HERC's role is going to be a little bit limited. My proposal will be to add coverage for metal-based dentures, and that is probably the extent of what the HERC will do, unless as internal staff we decide that a guideline is needed, in which case we'll bring that all back to you. The next steps in making a rule, Jessica Dusek, are you still in here? And can you speak to that?
She told me she had to hop to a different meeting, so
no worries.
I'll follow up with her by email.
Yeah, so generally, rules are done through a different. The HERC has nothing to do with rules. We liaison with our colleagues who do rules, but Jessica Dusek is usually the person who is in charge of the dental rules, and we will work with her, and we'll make sure that you all hear the next steps.
Yeah. I heard today, so there's the number of teeth, hygiene, exceptions for allergies.
I have material indications, hygiene, number of missing teeth, which teeth are missing, and time between replacement. Those are the topics that I have.
Great, thank you.
Manu?
Thank you again, Ariel. This has been more informative and a more transparent process. So thank you for taking the time and energy to listen to all of us. I did want to go back to two comments that I made earlier. One of them is the removal of OHA's statement that there's cost neutrality with partial dentures, as the intent of OHAP and HERC is really meant to be more evidence-based, or what, like clinical appropriateness, essentially, as opposed to talking about finances. And then the secondary comment is if it could be openly shared what the forums are, what the processes are in order to best advocate for, again, the cost of dental service delivery, and ensuring that while we're having a very strong, transparent process with evidence-based care, I think similarly on the opposite side of that coin, there similarly needs to be a strong and transparent process with the financial costs in the system as well. So if that can be, while I realize and understand this is not the forum for it, however, a path of what that process is will help guide conversations to improve our benefits. Thank you.
I already made a note about removing the cost comments based on your earlier comment. And then Ahmed, do you want to say anything about the rulemaking process or any communication questions?
No, thank you, Ariel. Once we receive your notes, I'll make sure that I'll follow up also with the rulemaking folks here and just take a look at our rule. I know that we're going to open it again, or we're currently in the process of opening the rule again to do some edits in the language for the handicap and malocclusion piece. The last rulemaking, as you all know, my understanding as I joined was that they're really just clarifying language, not changing or adding or removing the benefits. So we have an opportunity to look into this for the 2027 and in the changes, and we have a lot of time for the other teams who have to look into these codes, where to add them, when to add them, when to submit this to CMS for a new open code or not, and the fiscal impact. So there are a lot of more process that comes afterwards, but just making sure that you are all aware that what HERC sends to the Medicaid team will be taken into consideration for the upcoming rule changes and fiscal analysis.
Great, thank you. Any other last business? Otherwise, I want to thank you again, and in terms of this group meeting again, I anticipate that we'll probably not meet again until September or October for the new CDT codes, kind of our usual cadence. But please send me topics or issues that are coming up either in your practice or that you colleagues bring to you, and we can start kind of storing those up for the next meeting. All right. Well, I'll give you all back 15 minutes of your time. And again, thank you all.
Thanks, Ariel.
Thanks, everyone.
Thank you.